Good evening all and karibuni. Okay, it is 5 minutes past 7. It's 5 minutes past 7. Good evening, everybody. Thank you very much for joining us today. My name is Elizabeth Kaemba, or Liz Kaemba, as many people call me. I'm a clinical psychologist and a learning specialist, and I will be the moderator for today's webinar. Welcome to all you, our participants. Thank you for taking the time to join us. Our topic today is on anxiety disorders. And we welcome you to suggest any future topics that you would like us to discuss. Remember, Tuesdays is the mental health webinar day. So any topics in mental health that you'd like us to address in the coming webinars, we invite you to please let us know. You can write this in the chats and we will take this into consideration. I'd like to welcome our hosts who are Kenya Medical Association, and I can see Dr. Amos Otara, Vice President for KMA, has joined us. Karibu sana.
Thank you.
Do you want to say something briefly before we start?
Well,
Dr. Otara?
Thank you so much. Since I'm late, I really don't want to affect the program, but just to welcome colleagues to this evening's discussion, and thanking you all for attending, and looking forward to participate and learn on the topic of the day. Otherwise, not much else. Thank you so much, colleagues, and welcome.
Thank you, Dr. Otara. I'd also like to acknowledge members of different associations who have joined us today. Kenya Medical Association, Clinical Psychologists Association of Kenya, Clinical Officers Association of Kenya, and National Nurses Association, and all the other members of the association and their leaders who are with us today. So without further ado, I think I'll go right on to introduce our speaker for today. So the topic for today, just so we are aware, is anxiety disorders. And anxiety is quite rampant. One of the disorders that is ignored or taken for granted until it becomes really serious and has to be dealt with. So it is a very important topic, even as we discuss mental health. Our speaker for the day is Dr. Chelagat Saina. She's a consultant psychiatrist at Moi Teaching and Referral Hospital. She's married and a mother of 2 beautiful children. She's passionate about community mental health, and she's an ambassador doing community mental health activities in schools and communities. Her hobbies include swimming, traveling, and meeting new friends. So I think without further ado, maybe we will ask Dr. Chelagat to please put up her presentation and she can start. Karibu sana daktari.
Thank you very much, and welcome all for the presentation. So let me put up the slides.
As you do that, I'll remind our participants to put all questions in the Q&A. In case you have any questions you want to ask, just write them in the Q&A, and our presenter will respond to them as we go, as soon as we finish. Thank you.
Okay, as we start, today we are going to go through anxiety disorders. And as Liz has already put it, it's one of the disorders where we kind of brush it, or we don't pay so much attention as we are seeing our patients, or it is hardly even picked until a patient sees several of us, until it now becomes so obvious, or it impairs somebody's day-to-day functioning. So it is good to learn and know the basic things, what is anxiety disorder, so that we can know how to handle them at any given point when we are seeing these patients. So today we'll look at anxiety disorder, and we'll look at what is normal anxiety and what is anxiety disorder. We'll look at the epidemiology of the general anxiety disorders. We'll also try and tackle the etiology, symptoms, types of anxiety disorders, diagnosis and management of all these anxiety disorders. So welcome for today's webinar. So let's ask ourselves one good question. When does anxiety become a disorder? So let's look at the normal first. An anxiety disorder, a normal anxiety is a normal human response. It is a normal situation when there is an evidence of a threat. So you'll always present with some element of worry. Anxiety is different from fear due to its cognitive component. We'll look at that more. Anxiety can be helpful and an adaptive in anxiety, given like if you were to give a lecture, definitely you will always get answers, but with time you know what to do and what to present at a given time. Anxiety becomes a disorder now when out of proportion, or when it significantly interferes in our day-to-day activities, your social, your occupational, at home, any aspect of life, you're not able to function totally. So that is when we say it now becomes a disorder. So let's compare fear versus anxiety. Anxiety on its own is just an alarming sign that the body will always react to something. It warns us of an impending danger. That is why it is an adaptive behavior and enables a person to deal with a threat. So what is fear? Fear is that response to the unknown, external, undefinite, or unknown contractual threat. Then anxiety on its own is a response to a threat that is unknown. It can be internal, it can be vague, it can be conflictual. So somebody or people who have no experience to anxiety can say this to you: life is too short, don't worry. Just have confidence, take a plug. It is all in your head, so don't worry, get some guts. Why can't you just cheer up? You know, those are things we always tell people. And somebody's telling you, I am feeling this fear of something. And this is all you will hear us telling our colleagues or friends somewhere. So we need to also watch on how we approach situations and scenes that and patients as we meet them day to day. Don't be quick to say that it's just all in your mind. You can do without it, you know. Get some guts, you know. Why can't you just cheer up when really somebody is going through a lot of stressful events? So let us look at some of the symptoms that somebody will present with when they have an anxiety disorder. They will definitely present with symptoms of diarrhea, dizziness, hypohidrosis, hyperreflexia, palpitation, papillary mydriasis, restlessness, syncope, tachycardia, tingling sensation, there's tremors, there's stomach abscess, and urinary frequency, urgency. So patients become very restless. They cannot stay in one position. Some will tell you, I feel like I'm going to die. I'll feel like my breath, I'm losing my breath. So those are the symptoms that they will always present with. So let us look at what we call epidemiology. Why are we talking about it? Anxiety disorder are commonest, affecting 30% of adults at one point in their life. So that is something that we need to address at most. Then 12%, 12-month prevalence is around 17.7%. Then women are prone to present with anxiety disorders compared to men, which is around 19.2%. And why do we say women more than females? Why do we say women's more than men? One, women will present with more because we think of the hormonal issues. We think of women are the ones who will always seek medication. Women, they have this tendency of health-seeking behavior compared to men. And men have this, culturally, they are told, you're not supposed to show that you have this fear, you're supposed to be this strong person. So rarely do they present with such symptoms. They have them, but they do not even know where to take these symptoms or to tell anyone. So it is higher in women because of that, because we say it a lot. And to notice that anxiety disorders often begins in childhood or adolescence. So this is just a chart to show us the parts of the brain that actually is involved in this fear response. We have the thalamus, we have the amygdala, the hypothalamus. And so with effects of fear, these parts of the brain are affected in one way or the other. We will look at that. So generally, let us look at what we talk about in mental health. The biopsychosocial model construes human health as a product of reciprocal influence of biological, psychological, interpersonal, microsystemic, contextual dynamic that unfolds over a personal and a historic life. As you continue growing, all those experiences you go through. The importance or centrality of these influences varies within a person over time. So this is what gives us this dynamic, and we know more about mental health. So when you look at this biopsychosocial model on mental health generally, what are these risk factors, or what are these things that actually associate or bring about mental illnesses? We look at the psychosocial factors, we look at the biological factors, the way they affect the body, look at the social factors. So when you combine all these is when you are able to tell these are the risk factors that can actually attribute somebody to have a mental illness. So we look at each as we look now at anxiety. What are these factors that contribute to anxiety disorders? So when we look at the biological factors, we think of genetics. What have studies shown us? That when we do there are studies that have been done to show the twin studies where hereditary factors have been brought about, whereby 20 to 40% are associated with having phobias and general anxiety disorder. Well, 50% with panic disorders. So with all those studies that they found with research that there is a twin, that there is genetic involved. Neurobiological, as we had looked from the other charts, that there are some parts of the brain that is actively involved in the fear circuit. So when there is overreactivity or overexcitation around the fear circuit, around the amygdala or the medial prefrontal cortex, when there is overactivity in this region, there is possibility of now somebody having anxiety disorder. And to add on the neurobiological, we also talk of neurotransmitters. We have various neurotransmitters that are involved in the anxiety aspect in life. We have neurotransmitters like GABA and serotonin. And in this particular aspect where we talk about anxiety, GABA and serotonin at this level is reduced in level. So once there's a reduction in levels of these neurotransmitters, there are possibilities or increased chances of somebody having anxiety disorders. And to add on it, we also see that when there is increased functionality of norepinephrine in the cerulean, there is always possibility of anxiety disorder. So there is a reduction in GABA, reduction in serotonin, but increased in the norepinephrine neurotransmitters. Another aspect we look at is that we have environmental and cognitive factors. So one of the environmental factors is the stressful traumatic events that can happen in somebody's life. One is like abuse as they are growing up, traumatic abuse. It can be sexual, it can be physical, it can be emotional, financial, in any aspect. Then there is death of a loved one or a close relative member, violence or prolonged illness. So all these being a stressor in the body can contribute in aggravation of an anxiety disorder. Another aspect is sustained negative belief about the future. Belief that one lacks control over the environment. They have this punitive parenting, the early childhood trauma that can also be related to the stressors to the upbringing of that particular child. Then there's the negative evaluation of to self now, where you have self, you harshly treat yourself, you put yourself into punitive self-judgment, that in the end, you're always saying, like, life doesn't have a meaning, you're always this negative person, and you end up being, you stick to that and you learn these behaviors until you become, now when you face life, because you're this negative person, you find yourself having anxiety problems. And then also fear of negative evaluation by others. You feel that people will talk about you, people will judge the way you talk, people will judge the way you dress. So there's that fear that comes in. So there are contributing factors. Another factor to talk about is substance use. Anxiety and addiction have several connections. So it's good to understand that. For some people, their anxiety can cause them to self-medicate with drugs or alcohol. That is very obvious because you'll see somebody who has an anxiety disorder, mostly social anxiety, they will find themselves going to take something like alcohol, and then they are able to socialize with other people and they will not fear being scrutinized. Another thing is people may use drugs in order to cope with anxiety. So when they are anxious, they will always take that particular drug. When they drink, it makes them feel calm. And as time goes by, they become dependent on this particular substance in order to treat that fear. So you continuously abuse this substance until now you become dependent to it. So you're already developing another disorder, substance use disorder, plus now and with comorbid anxiety disorder. People with history of trauma are more likely to develop anxiety and addiction. Genetics and chemical imbalance in the brain may cause both disorders. And for others, addiction can cause anxiety. Some will use substances like cocaine that impacts parts of their brain that corresponds to stress. It increases stress hormones, encourages dependency, and facilitates anxiety disorder. So you see the way substances can actually lead to anxiety disorder. And then relationship can be bidirectional. So it can either be the drug that is making you anxious, or you can be anxious and you're using the drug to clear the anxiety. So it can be bidirectional. So let's now go into specific, into the kinds of anxiety disorders that we see. So we have what we call specific phobias. And in specific phobias, it means you have fear for a specific thing. It can be an animal, it can be a place, it can be an environment, it can be anything but one thing in particular. You're specific to that particular thing that you're having fear for. So it is selective, persistent, and out of proportion fear of worry of that particular specific thing. It includes cognition that can lead to behavioral response, whether or not the threat is present. So sometimes when the threat is not there, but they have that in mind, the memory of that particular thing is always there with them. Maybe genetically, neurologically, or experiential based. So depending on where, maybe there's family history, maybe they've had a neurological problem, or maybe they've had an experience once with that particular specific thing that is making them have the fear. Then we have another anxiety disorder called social phobia. It is more pervasive, highly cognitive type of phobia. Distinguishing features for this fear of doing something in front of others for fear of being judged. So that's scrutiny. Maybe situation, it may be a situation or in context. So you're meant to perform somewhere, you're meant to present a presentation somewhere, but that's the fact that you're not able to stand in front of people and give that presentation. A patient will present with the particular symptoms you had mentioned earlier, and they may not be able to function normally as expected. The fear of one's being own behavior causing negative attention to others, the symptoms actually interfere with important areas of functioning or causes marked distress. So apart from just having the fear, it causes marked distress in all aspects of life. So that's one thing we need to know, the difference between now a disorder and abnormal anxiety. When they have a disorder, there is marked impairment in their social occupational functioning. Another disorder is panic disorder. So it can happen in two types. There is with agoraphobia and without agoraphobia. Consists of a pattern of recurrent panic attacks, emotional, physical, cognitive, behavioral components. Main fear is losing control. So the consequences is they will die or they will go crazy. They'll get embarrassed, not being able to get help. So the fear of having a panic attack comes a problem of its own, of itself, possibly leading to agoraphobia. Now, what is agoraphobia, as you had mentioned there? It is just that fear of space, crowd, etc., a place where escaping or finding help is difficult or embarrassing, or other phobias. And then another phobia, another anxiety disorder is generalized anxiety disorder, which is characterized by persistent and global worry. You worry about everything and nothing. We cannot put a finger onto one specific thing. It is everything and nothing at a given time. So distinguished from normal worry by severity, the interference and irrationality. The common problem, it is a common problem, but it is not, and little is known about it. Symptoms interfere with important areas of functioning and causes marked distress. That one should be always emphasized. The symptoms interfere with important areas of functioning and causes marked distress. So when you look at this, is just a general chart to look at how they will present when they have general anxiety disorder. Yeah, so there's that excessive worry. When they are worrying a lot, they worry to a level that they get fatigued. They become restless. They cannot even sleep. They become irritable. You ask a question, they will respond in a manner suggestive they can be violent to you at that point. There is impaired concentration. There is increased muscle tone. So there's many symptoms that they will present with. Another anxiety disorder to talk about is separation anxiety disorder. According to DSM-5, separation anxiety disorder is primarily characterized by an individual fear of leaving home or parting away from a certain individual. This anxiety must exceed what is expected at an individual's age and developmental levels. So there is this regular excessive distress when they separate when they leave home or they leave that particular person. There is worry about losing this individual. They regularly worry about experiencing an unfortunate event, like they are going to get lost, they will get sick when they live away from this particular person they are used to. There is persistent reluctance or refusal to go anywhere, to do anything out of fear of separation from this particular person. Another anxiety disorder to talk about is selective mutism. According to DSM-5, this selective mutism is a childhood disorder. Number one, you notice that. Childhood disorder, typified by inability to speak in certain circumstances. Specifically, it consists of failure to speak in certain situations where there is natural expected to speak. You're in school, when you're at home, you speak well to your people, but when you get out, you come to school, you cannot talk. But when maybe it could be at home, but when there are many people around you, you're not able to talk. When you're just between people you're used to, your father and mother, you're able to talk. When the crowd increases, new faces, you're not able to talk. So the child may be verbal at home, but unable to speak when they're in classroom environment. And it is believed that this is a form of a social phobia and is not recognized before the age of 5. So how do we diagnose anxiety disorders? So we are using DSM-5 specifically to help us see if these patients qualify or they fulfill the criteria for diagnosis for anxiety disorder. And the symptoms are experienced for almost every day for at least 6 months. But if it is for panic disorder, it can be onset and it can be within minutes and days or hours. So that's the difference between the general anxiety and the others. Panic attacks can happen at any given time because of a certain fear. So it can be within minutes, seconds, hours, days. But this other one is the symptoms should have persisted for at least 6 months. What investigations would you want to do? You need to do some tests at least to rule out if there could be any other illness or an issue that could be actually triggering this. So you need to check on the TFTs because we need to know, is this person having hyperthyroidism? Check on complete blood counts. How are the blood counts? Check on the sugar levels. Urine toxicology. Could there be a substance that this person is using that could be actually making them behave the way they are behaving? We also need to rule out things like pheochromocytoma. Need to check on ECG echoes to check if it is a cardiac problem. So as we are doing this, we are trying to look at the differential diagnoses. What could be the other cause of this problem we are having at hand? So this is the differential diagnosis. You need to rule out if there is any other thing that could be causing this anxiety. Is it a vascular disease? Is it pulmonary? Is it neurological, endocrine? Drug intoxication, withdrawing from a particular drug? Or is it any other illnesses like SLEs? Could this person be having some metal poisoning? Or any other infections or diseases in the body? So it's very, very important to rule out and know exactly what are we dealing with. Is it purely an anxiety disorder or is it an anxiety disorder because of another medical illness? Then you also need to differentiate from other psychiatric disorders like major depressive disorder, eating disorder, sexual disorders, substance use, somatic symptoms, personality, and many others. So you need to differentiate and know, is this purely an anxiety disorder? Because at most you'll find that most of these, they overlap. You have, like, they are more comorbid to the other. You'll find somebody who has depression comorbid with anxiety disorder. But now we need to know, is this purely anxiety or it is because of something else? So let us go now to the treatment. As we've done the investigations, we've done our differentials. So what are we going to do to treat these patients? At most, we will give antidepressants. And we have various antidepressants that we could give. We have the SSRIs, SNRIs. At some point, we even use bupropion. We use benzodiazepines, beta blockers, propranolol, for example. And sometimes we can use anticonvulsants, antipsychotics if there are any comorbidities, because you'll find maybe they are having depression, maybe with anxiety, they're having psychosis with anxiety disorder. So we need to know how to treat them in all those aspects in life. Apart from medication, we have to also use what we call psychotherapies, and we have different psychotherapies in regards to anxiety disorders. We have behavioral, we have cognitive behavioral therapy, CBT, where you look at the systemic exposure to fear situation. We have self-guided treatment which is effective. Then we have social skills training on how to encounter and how to interact in situations where you meet with what makes you fear, so that you don't have these avoidance, because that is always what biggest challenge. People try to avoid what makes them scared in life. Then to add on is, when we are doing all these treatments, we need to use combined therapy, where we combine medication plus psychotherapies. And we've seen that there is better outcome when we do both. And sometimes we might just need to use psychotherapies alone without initiating medication. So I think after assessment and looking at the patient thoroughly, you can make your judgment and see, do I need to put them on medication, or do I need to do psychotherapies, or do I need to combine both, or do I have to just do psychotherapies? So it depends on the assessment of the doctor at that given time. So this is just a repeat of the same. And I think I am done. Thank you. If any questions.
Thank you, Doc. Very important topic, anxiety disorders. We have some questions, and maybe I saw a question pop up in the chat. Please post your questions in the Q&A so I don't miss any, but in the meantime, I'll start with the ones in the chat. So the first question, are patients presenting with illogical somatic symptoms like Hapa syndrome considered as having generalized anxiety disorder? Doc, maybe you can take that for us.
So patients presenting, yeah. So for anxiety disorder, of course, apart from them being anxious, they will always present with all the other symptoms we talked about anxiety, where they'll present with other symptoms of palpitations, excessive sweating, not able to concentrate, shortness of breath, and all that. But when they come with Hapa syndromes, where you're not sure what is the cause or what is the problem with the patient, there's always a difference. So you need to know that when they're having anxiety disorder, they will always present with all the other physical symptoms. But Hapa could just be because it's like attention seeking kind of, or maybe they have the somatization, somatic disorder. So we need to take further history and know what else could be the problem. Is it a psychosocial problem? Because at most when they have factitious somatic disorders, they will always present with Hapa syndromes.
Mm-hmm. Okay, thank you. So somebody else, Philip Wechuli, is asking the difference between selective mutism and agoraphobia. Would you maybe enlighten us?
Okay. When we talk of agoraphobia, agoraphobia is fear of an environment or a place where they are and they are not, where they feel help might not be possible. For example, there is fear of being in a lift because it is a closed environment. That fear of just being in a closed environment where when they look outside, they cannot see how they are going to get help. That is agoraphobia. Selective mutism, on the other hand, is fear of talking in particular environments where it is either a new place, a place they are not comfortable with. Like for now in children, we say they go to school, they are not able to talk when they're in class. But when they're at home, they are very comfortable. So the selective mutism is more of like a social anxiety disorder. That is a big difference from agoraphobia.
Okay, thank you for that. That I think is quite clear. But someone else is asking, Peter Juma is asking if selective mutism can be diagnosed in adults.
Selective mutism, I think when we see selective mutism, mainly we have as an underlying psychiatric disorder. Like when patients have schizophrenia with negative symptoms, you will always find them to be having selective mutism. So it is possible to find selective mutism, but now here it is more as a psychotic symptom.
Okay, thank you, Daktari. Evans is asking, is the difference between anxiety and panic disorders? Okay, panic disorders are part of anxiety disorders, but he's also asking, is there any impact of long-term anxiety disorders? What is the impact of long-term anxiety disorders?
Okay, let's imagine this is somebody working in a factory where they are only using machineries, and you have this fear for this particular, like now using the lift. And the only way to take things from one point to the other is using the lift. And I have this fear of using the lift. So at some point, I will not be able to function at work, because the moment I am told now, take the lift, take these things to the 3rd floor, and this is the only way to make these things get there, will I be able to be productive at work? No, because the moment I see the lift, I get anxious and I'm not able to concentrate at all, and that is the end of me. I will not be able to function at all. So it will have an impact at work. It will have, if you think about now, and because that question will go into anxiety at work, it will affect you in terms of your promotion, because now when it comes to promotions, when you're told now you're supposed to go and sit and face a panel that will be giving questions concerning why you think you need promotions, you will always want to avoid. You will also look at when you're supposed to give presentations at work and you're supposed to give, it has to be something productive. You'll always have excuses for why you should not be the one to present. Yeah, you're told to go for work-related activities out of town where you'll be away alone, maybe with other investors outside of your place of work. But because of fear of being with other people, you will not be able to function. So in a big range, you see that it will really affect your work. It will affect you at home. It will affect you with people around you.
Mm-hmm. Okay. Well, we are having many more questions coming up, so I'll try and take as many as possible. Somebody is asking, Maura K. Martin is saying, thank you for the wonderful presentation. Do these anxiety disorders occur alone, or are there any comorbidities?
Anxiety disorders can occur alone as a disorder, but at most we've been seeing a lot of comorbidities. I think that is one thing we need to make it clear. We've been seeing a lot of patients with anxiety disorder, with a first primary disorder, maybe like major depressive disorder with an anxiety disorder. So we've been seeing a lot of comorbidities.
Yes. Okay. Another attendee is asking, is PTSD also a type of anxiety disorder, or is it a different mental illness altogether?
I think according to DSM-5, it is no longer clustered as one of the anxiety disorder. It is it's not part of the anxiety disorders. I can't remember exactly where in particular. The PTSD was put aside. It's not part of anxiety disorder.
Okay. An attendee is asking, kindly tell us the duration of management and dosages. I don't know if we can discuss dosages here, but duration of management for, I think, pharmacological treatment.
I think treatment is dependent on, it's individual to individual. And apart from, as we had said about treatment, it's not just medication that we will give, we also have psychotherapies. And most of these, if you look at research, it shows that most anxiety disorders are very hard to control. Because you can, you might start treatment, but along the way, as you're giving medication, they might develop another comorbidity one. They might also have, or they might, the issues of compliance to medication might come in. So bringing up the issue of how long we can give medication, I think it is patient to patient dependent also, and on the severity of the symptoms of the patient. What are we putting the patient on, medication alone or plus psychotherapy?
Mm-hmm. I think psychotherapy, I do agree, as a clinical psychologist, psychotherapy is very important for anxiety disorders. And it ties in with this question that, this statement and question from an anonymous attendee who says, I was diagnosed with generalized anxiety disorder a few years ago. I was put on escitalopram for about 10 months, which somewhat helped. However, I didn't and still don't like being on regular medication regimen. Hence, I stopped the medication abruptly. Is there a way to fight this problem without taking medication?
Yeah, I think now for this patient, we really encourage CBT to help with the anxiety disorder. Yeah.
CBT being cognitive behavioral therapy, which would be offered by, a clinical psychologist.
Yes.
yes, definitely.
Thank you.
Another attendee asked, how do you diagnose generalized anxiety disorder? Maybe I'll answer this one. As Doc said, we use the diagnostic and statistics manual. We look for if the patient meets criteria, and then we are able to make a proper diagnosis. for generalized anxiety disorder. So I'll ask you this one. Silas Wafula says, thanks, Doc. In a case where anxiety occurs together with a physical illness, is it okay to manage the anxiety as well or just deal with the physical illness? Doc?
So to answer to that, yeah, I'm here.
Mm-hmm.
To answer to this, I think the first thing to do is to deal with the physical illness, because the anxiety could be actually attributed by the illness itself. So as you take through the patient to find out, like you're trying to handle the physical illness, you might need to, once the physical illness will have been sorted, you will find that at most, the anxiety disorder will also go away. But at some point, you might also need to add them some antidepressants or something to help, or some beta blockers, depending on the symptoms that they present with the anxiety. But the first thing and the most important thing is to deal with the physical illness first.
Mm-hmm. Yeah, that's true. Mera Rita asks, when do we prefer anticonvulsants and antipsychotics, and which of them are like the first line as far as management of anxiety disorder is concerned?
Maybe I could leave somebody in the floor to help here, but as I was going through, most of the patients that are put on anticonvulsants, you will find that there is a comorbidity at most. That is why we are putting them on anticonvulsants. Because most of the time you will see that they will do very well with antidepressants. But if you were to specify and say particularly which antidepressant, an AED that you would use, I think yeah, would need somebody to assist and see what, I don't know, their views on this. Somebody could give an input to this.
Okay. If you'd like to give an input, please just raise hand, and as we go ahead with the rest of the questions. Lorraine asks, can having chronic normal anxiety lead to an anxiety disorder?
So our question we need to ask ourselves, what is this chronic anxiety? So and what is chronic normal anxiety? What do we mean by this? Because by the time you're having continuous and persistent some anxiety symptoms, it already tells you that this is an anxiety disorder. It is persisting, it's pervasive for a period of time. So that already tells you this is an anxiety disorder. So we need to treat it as an anxiety disorder, because if you're having normal anxiety, and is it chronic to a level that it is affecting your day-to-day functioning? Those are things that we need to find out. And if it is affecting you in all aspects of life, we take it as an anxiety disorder.
Yeah. Nancy Mose asks, here is a question about compulsive disorder. The patient tells you he confirms his doorknob after closing each night. So maybe I'll take this one. With obsessive compulsive disorder, which I think is maybe what you're asking, if you confirm your doorknob just once or twice after closing each night, there is that may not completely qualify as an obsessive compulsive disorder, but depending on how many times he checks each night, or if he does other things where there's a compulsion, then that may and meet other criteria as per the DSM, then maybe that may be considered as a compulsive disorder. But just checking to confirm if you've locked your door at night once or twice, maybe that might not qualify as a compulsive, as an obsessive and compulsive disorder. So I'll send this to you, Doc. Amos Njoroge asks, is anxiety disorder related to motion sickness?
I don't think it is related to motion sickness. Motion sickness is when you are traveling, you have this nausea, vomiting, sometimes even feel like you're having diarrhea. I don't think it has any relationship with anxiety.
Okay, any relationship between dementia and anxiety?
There's a lot of information about or research about major depression with anxiety disorder. So there's a comorbidity a lot on these two.
I don't know if you answered this question already by Mbogwa Paul. What's the best approach as far as pharmacotherapy is concerned between antidepressants and anxiolytics? Hello, Doc?
Yes, I'm here. If you look at antidepressants, we mainly use it for a longer period of time compared to anxiolytics, because anxiolytics, there is tendencies for abuse and dependence. So we'll only use the anxiolytic for a very short period of time to calm the patient down. Then after that, you might need now a long-term drug like an antidepressant that will help the patient for a longer period of time, and we are not worried about abuse of these drugs or dependence of this particular drug. But when you use the anxiolytic for a longer period of time, of course, for sure, you will now have another new diagnosis of dependence to this particular drug.
Okay. Somebody asks how long anxiety disorder takes to heal. Again, I think this is something we say is quite dependent on the treatment you obtain and dependent on person to person, basically. So if you go for therapy and you get psychiatric support, pharmacotherapeutic support, and of course yourself and your situation, then that will determine how long it takes to heal. I don't think we have really a specific amount of time. Then the next question, this attendee says they've been diagnosed for treatment. For me, I'm diagnosed of treatment-resistant depression and social anxiety disorder, which was triggered by trauma. I was bullied by other people in class 3. Then I was, when he or she was 8 years. I've used everything. What help can you please give, at least shortly, as I look forward to more help? Is there anything you can tell this attendee?
So this patient is somebody who needs to be in close care and monitoring. I think he needs to be on follow-up by a psychiatrist, because 1, he still needs to be on his medication. 2, he needs a psychotherapist with him also, because as part of treatment, we need to combine the two for him, because if he says he's used everything and he feels he's not yet there. So we need to do a lot of cognitive therapy here to help him change his mindset in terms of what is actually triggering the symptoms for him. And I think we could also have a private chat with him. I'm seeing he's put his email and phone number. We'll try and see how to help.
We will actually reach out and have him maybe seen by our people at the call center. So again, our attendee who asked this question, please take the contact of the call center at the end of this presentation and call, and you'll get a free session or free sessions, and maybe a referral if necessary. Somebody is asking, could you please talk a little more about TBT as a way of dealing with generalized? I think you meant CBT as cognitive therapy. I don't know what TBT is. Doc, do you have any idea?
I think this person meant to ask CBT.
CBT, yeah, cognitive behavioral therapy.
Dealing with general anxiety disorder. Maybe you could talk a little, Liz, about this.
Well, cognitive behavioral therapy basically is it addresses how you think, how your thinking affects your behavior, and sometimes we know anxiety may be caused by other environmental issues. So as we go through therapy, we deal with your thoughts, relationship with your behavior, and how it affects you then as a person in your day-to-day activities. So that's what basically cognitive behavioral therapy does for generalized anxiety. And this is done in a therapeutic setting. So you'd likely want to see a clinical psychologist or a psychotherapist in this regard. So the next question is, can a psychiatrist offer psychotherapy like CBT along with medication without having to see a psychologist? Let me take this one. Some psychiatrists are actually trained in offering therapy and do offer therapy, but not all. In our setting here, a lot of our psychiatrists, because of the load of work, and Doc, you can correct me, they will likely do the diagnosis and pharma and refer you to a psychologist for longer term and more intensive psychotherapy. I don't know if I answered that right, Doc?
Actually, that is true. According as per our training, majority of us, to be sincere, majority of us would always prefer a psychologist to take through most of our patients through the CBT. They are more more advanced in terms of how to go about it better than us, though we have the little knowledge on how you could actually initiate it, but it is best done by a psychologist.
Thank you, Doc. Another anonymous attendee asks, and we'll take maybe 2 or 3 more questions, and then we are done we'll move on with our program. Do patients with anxiety also experience suicidal thoughts and tendencies? Dr.
I think that could be very true, because you can imagine it is something that is stressing you to a level that you cannot function, you cannot concentrate. And sometimes it reaches a point where you do not know what to do next. And the only thought that comes to your mind is suicide. So suicide is very much possible.
Yeah, that's sometimes people do get suicidal, mostly because of a lot of frustration, and also the physiological symptoms of the anxiety can really cause suicidal ideation. So another attendee asks, thanks for the presentation. I have a client who suffered a neonatal loss, developed depression thereafter, but didn't take medication. She has since become so irritable to her other baby. Could this be a disorder?
This is that is a disorder, because one, that is depression, we're already picking up from there. So, and this is somebody who will need care, because by the time you're already having the irritability now towards your children, it means like that the interest or the loss is becoming a center of interest to you. When you look at this child, you feel maybe you have this fear of even losing this child also. So chances of developing depression is very high, and she's already bringing out some symptoms of that.
I'll take one question here, then I'll give you the last one. During management of anxiety disorder, do we start with psychotherapy or pharmacotherapy, or do we combine both at once? So I would say, depending on who provides a diagnosis, if you are seeing a clinical psychologist and they are able to give you a diagnosis of anxiety, any of the anxiety disorders, they will be able to determine if you need medication, or if you can just do well on psychotherapy alone. But as Doc has said, usually we find that depending on the level of anxiety that you have, psychotherapy and pharmacotherapy work very, very well, work best together. So it's always best to combine both depending on the level of if you're having mild, moderate, or severe anxiety. And Doc, I'll give you this one as our last question. I'm sorry to all the other people who have written and we have not answered the questions. Are there situations when overfeeding or overeating is a manifestation of an anxiety disorder?
Here now we are talking of eating disorder. So eating disorder can be a manifestation of an anxiety disorder? It could be yes or no, but I have a feeling this is more of an eating disorder which needs to be addressed. And if they could be presenting with other symptoms of anxiety, we think of comorbidity. So here it is, which one came first? Was this patient anxious, or did this patient have anxiety disorder prior to this overfeeding? Or did the overfeeding come as an eating disorder? But now because they are becoming so curious and they are learning more about their surrounding and the way the situation they are in, this alone could make them anxious, and they are not even able to face reality. They could develop even social anxiety disorder. They would have this issue of not being able to interact with other people because of fear of what people will say about them. So, and there is the issue of judgment. You're scared of people to judge you. So we will talk first about one as an eating disorder, maybe now as time goes by with comorbidity as an anxiety disorder as a comorbidity. Because one, they start having issue of being judged. They have self-image issues. So, and that alone about anxiety.
Okay, maybe let me just take this one final question. Is there a relationship between increasing cases of anxiety and mogoka or cat use? Do you have is there any research on this? Doc?
What was the question? The use of relationship.
The relationship between, yeah.
Mira use and anxiety.
Yes. And mogoka.
One, as I had talked about the initial slide about substance use and anxiety, is that it can be bidirectional. So it could either be the person having anxiety prior, and when they use this mogoka, it helps them reduce the symptoms. Or they could be using the mogoka that actually aggravates or brings about more symptoms of anxiety. But for me, I would say for me personally, maybe I have no research that could suggest this, but out of, if you think widely about it, addiction on its own could actually bring about it, or use of, or the anxiety on its own could make you want to continue using this because it helps calms you down or something.
Okay, so thank you very much, Dr. Chelagat. Wow, that was a presentation that has seen so many questions today. We've had almost 50 questions. Thank you for that very, very informative presentation. And now I think I'd like to ask Peter to project the call center numbers. Please note, as I had mentioned before, if you do need to call somebody or you need to talk to somebody, if you're having anxiety or anything else, please call our call center. The call center is managed by healthcare workers. It is a call center that was created for healthcare workers. So it is specific, it's specific to us. It is managed and run by healthcare workers. So anybody who picks your call will likely be a healthcare worker, either a psychiatric nurse, a medical psychologist, and if those who have done specifically mental health, who are in the healthcare sector. So we have this call center specifically for us. Yes, as Dr. Haas has mentioned, down there, CPD points will be sent to your emails. Note, we all register using an email, so all the CPD points will be sent there. Also, the recorded webinar is on the KMA site and also on the KMA YouTube page, so you can get the recorded webinar from there. And I've seen Peter has also talked about the webinar this coming Thursday, which is going to be held. This is for mostly healthcare workers in physiological health. Ours is a mental health webinar. So for now, I'd like to thank everybody for coming. I want to give an opportunity to Dr. Haas to please close for us the webinar today. Dr.
Thank you so much, Dr. Hayemba, for working with us through this webinar. Asante sana, Dr. Chelagat. This was very informative and very timely. I've seen Dr. Marion. Asante for joining us today, and Dr. Otara as well. To our participants, thank you for taking the time and also for asking questions. This has been a very interactive session. So until next week, take care of yourselves. We'll see you again on Tuesday at 7 p.m. And to you too, Peter. Asante sana.
Thank you all. Thank you.
Thank you. Bye-bye.